it's continuous. It's keeping it open all the time.
Okay, so what does PEP therapy also help with that these others don't necessarily? Clearance secretion. So there, keep that in mind when you're thinking about making choices for increase in lung volume. So now let's look at the assessment outcomes real quick. Absence of or improvement in signs of atelectasis. Decreased respiratory rate. Remember, rate is directly proportional to the amount of atelectasis. Resolution of fever, their pulse is going back to normal, their breath sounds are improving, their AA gradient is getting more towards normal. Down towards the bottom, their vital capacity and peak expiratory flows have improved. You with me? Okay? So I just wanted to reiterate that patients with flail chest are probably going to need some type of lung inflation therapy while they are waiting for those rib fractures to resolve. Now, it may be that, does anybody know what they used to do, either from TV or maybe from a family member or something? What did they used to do if someone came in with broken chest or broken ribs? They put this band around them. They would try to stabilize them. What does that do, though, when you've got a restriction on the chest? It's going to restrict their inhalation even more, and thus more atelectasis and so forth. So typically, if their flail is bad enough, they'll go ahead and put them on mechanical ventilation, and that way we can sedate them somewhat or even paralyze them and give them positive end expiratory pressure to keep their alveoli open and give their ribs time to heal. Yes?
There's not much you can really do for broken ribs, correct?
No, they just have to,
Heal on its own.
yeah. So, but we need to keep them stable.
Right.
So, the way to do that and prevent pneumonia and bad things from happening is mechanical ventilation and PEEP. And that's going to, again, it's going to rest them, because it may take up to 10 days for healing to occur, depending on, again, how severe the rib fractures are. And it may be that the patient is able to tolerate the pain and they're able to take deep breaths just because of where the location is, and they don't need the mechanical ventilation, but they may need the lung inflation therapy. Ultimately, we're going to look at blood gases, we're going to look at their chest x-ray, and we're going to gather lab values and so forth to determine if mechanical ventilation is the way to go for them. Does that make sense? Okay. So these are some things that can lead to flail chest, motor vehicle, falls, blast injury, someone's working, Daniel, you may be able to give us a better example than I can. Someone's working around mines or somewhere where they're doing explosives, and someone's didn't get to the place where they were supposed to be, and all of a sudden they get, or either the bomb on when they had the marathon going on. There was probably some blast injuries from that. So, when you fall on your chest or on an area, there's a potential. Direct compression by a heavy object, occupational and industrial accidents. So usually this is something that's going to happen in a workplace, or it's going to happen while you're doing something. Okay, and once again, we keep looking at these pictures of these kind of algorithms, but they never change. Okay, we're just continuously looking at them so that we realize any time that we have atelectasis, we're going to have shunting, we're going to have VQ ratio problems, we're going to have hypoxemia, and we're going to have venous admixture. And what's going to happen because of the low oxygen is the peripheral receptors are going to kick in. Different reflexes are going to kick in, deflation reflex and the irritant. And then that's going to cause our vital signs to go a certain way. It's going to cause our lung volumes to go a certain way. And it's going to cause our ABGs to go a certain way. Does that make
Is that what you were asking for in the test too? What would happen?
I know I asked about VQ, I asked about venous admixture, and I was looking for you to tell me something along the lines of a good normal PaO2 gets mixed with the low PaO2, and ultimately the PaO2 that leaves the pulmonary veins is lower than normal. So that's my thought process, because that's what happens. So I'll have to look at what you put.
I thought that was multiple answers to
That's what I
that
put.
question.
There it is.
I didn't count that.
That's
If all of us got that wrong, can you just like knock it off?
I don't know. But from this point forward, venous admixture's not going to change. And anytime you have atelectasis, from whatever reason, you're going to have areas of good gas exchange, and you're going to have areas of bad gas exchange. And when you have the good PaO2 mixing with the bad PaO2, ultimately the PaO2 that leaves is going to be bad. It's going to be decreased. That's admixture. And that's what stimulates the peripheral receptors to try to get some more oxygen into the lungs. But ultimately, the body's not going to be able to keep up, and what is going to have to be given to the patient? Oxygen. Does that make sense? And I was also, the other kind of explanation question that you had was about dead space.